providers. We're super excited. My name is Charity. I am the JADA clinical educator. I have L&D experience. I worked at the bedside at a few hospitals up and down the 95 corridor in Virginia. I was still working at the bedside until December and as a PRN, but the system I was working for said it was not okay to do both. So I'm here full time and I love it. And I'll let Terry introduce herself before we get into the demonstration.
Hi, I'm Terry Spiegel. I'm your JADA territory manager. I probably know some of you, or some of you know me. I've been in the OB sales world for too long to say, but I'm really excited to meet those of you that I haven't met yet, work with you again for those of you that I have, and JADA is very near and dear to my heart as I am a story of hemorrhage, but JADA was not around. But please reach out to us. We've put our contact information in the chat via text, email, call, whatever is easiest for you. We're available 24 hours. So I'll turn it over to Charity.
Also have your contact information in our physician lounge, so it's easy for everyone.
Perfect. And really and truly, we want to be here to support. I just got a call from one of our other hospitals this morning with questions. There's no question that's, too small to call. We want you to feel supported. This is a new tool. We want you to feel like you have, all the support that you need. So feel free to reach out, text us, or call us. We are available for in the moment questions. So before I get started with the actual demo, we have the JADA device in the uterus here. We're going to leave at the hospital for the week. We're going to leave both of these things there. So if you guys have a central location, want to get your hands on it, weren't able to attend one of our live trainings, you can actually get your hand on the device and practice with it. But before we do that, we like to sort of just talk about, what is JADA, spend a few minutes because this is a new tool. We're not looking to replace or take anything away from the existing toolkit. We just are looking to add to it. JADA is an intrauterine device that's used in the setting of abnormal postpartum bleeding as well as hemorrhage due to uterine atony. So this is specific to uterine atony, but that does account for about 85% of our hemorrhages. So the largest majority of our hemorrhages. And it works by that low level vacuum suction. So if you think of take out the medical aspect of it. And if you just think of deflating an air mattress or the vacuum space saver bags that we use to put underneath of our bed, that's the mechanism of action that we have in place. So what we're going to do is we create a seal. So there is a balloon, which is this part on the device here, and it gets placed into the patient. And this balloon is not actually in the cervix. It's not in the uterus. It's actually in the vaginal canal right up against the external os of the cervix. And it's acting as like a cork, basically, to trap everything inside of the uterus, all the air, blood, fluid inside, and create negative pressure. So when we hook the vacuum tubing up to this port, there's only one exit. And so everything should be coming out of our tube. And as that happens, if my palm here is the uterus, as that happens and the evacuation is occurring, we then see a collapse of the uterus. And so the uterus will then be mechanically contracted or mechanically collapsed. And we keep it mechanically collapsed as long as she's on that low level suction. Suction is set to a very light suction. It's 80 millimeters of mercury. There's never any titration one way or the other because with the way that this is working, it just doesn't make sense to titrate it down. We know that 80 is going to give us that collapse. We don't know that anything less than 80 will give us that collapse, and we don't want atony. And then going up stronger, we don't know how, if that's safe for tissue. It wasn't tested. So it's always going to be that 80 millimeters of mercury. And this device is not just for controlling the bleeding, it's to control and treat the atony, which is the other big thing with this. You're actually treating the atony by giving that uterus time to rest. It doesn't have to work or do anything while we're controlling giving it that contraction. So during that time that we have her on continuous suction, the patient's basically resting and allowed, time for that uterus to recuperate. So when we take her off of the suction and now her uterus is functioning on its own, it's had that time to rest and it can, contract the way that it's supposed to. So a couple of the numbers that we look at, the average time when we hook JADA up, the average time to collapse of the uterus when we've hooked it up is an average of 60 seconds. And then an average time with that, collapse and closing off of those blood vessels, the average time to control of the bleed, which that's where do we see it stop in the tubing? The average time to control is 3 minutes. So if you're looking at a situation that's unfolding very quickly, or maybe it's slow, you may have had time to do other interventions. This is not something we're saying use in place of or instead of. It's another tool in the toolkit to use in conjunction with. And, if you have a situation where your patient is bleeding very quickly and maybe she has a couple of your uterotonics that she's not eligible for based on other comorbidities, this might be something you utilize before other things. If things are unfolding and you have time to give a dose of methergin and then wait to administer another dose, this may be something you do after. You have a lot of leeway in terms of provider discretion. There is an algorithm, I believe, where for the Inova systems where they have, I think it's after the second uterotonic. But from a JADA standpoint, the indication is abnormal bleeding as well as hemorrhage. Are there any?
It's the use of the use of 2 medications for control of bleeding, uterotonic or TXA.
Yes, sorry about that. Yes.
For our Inova protocol once you're done.
Okay, perfect. So any questions about kind of what JADA is, how it functions, when you would be looking to utilize this before I go into like the demonstration piece of it? Okay, so this is always the exciting part. I'm going to talk a little bit about what JADA is in terms of how the device looks. So this is the JADA device. When it comes, you have a box. Inside of the device, we provide the JADA, which is all in one piece. And then we provide a 60 cc syringe and then the 12 feet of tubing that gets hooked up to the wall suction. This is how JADA looks when it comes out. We ship it with a little bit of air in this seal just so it doesn't get compromised. It's all medical grade silicone except for these 2 pieces down here, which are plastic. This is what's called the intrauterine loop. So when this is placed, this sits in the lower uterine segment. So we're not going up to the fundus when we're placing JADA. It sits in the lower uterine segment, and the idea is that we're going to get the uterus to collapse around it. If you flip this inside out, you can see these little pores. So I like to say that JADA is my vacuum for air, blood, and fluid. It is not a Hoover vacuum or a yank out. We're not trying to suck out placental fragments or big clots. Prior to placing JADA, you're going to do a manual sweep before we put JADA in. And that's regardless of whether you've done one previously. If you've been managing the patient and she's been boggy and then firm and then boggy and firm, and you did a manual sweep early on, you'll want to do another one right before placing JADA. She's still bleeding. We're still intervening. There could be additional clots that have formed. This part right here is going to be in what's there of the cervix. And then again, this seal goes into the vaginal canal, and it's going to go right up against the external os of the cervix. So we're not going inside of the cervix or inside of the uterus. And this port right here is where you're going to take this air out, and this is where your fluid will get pushed in, and then this is what's hooked up to suction. So that's pretty much the entirety of the device. You can see that this is very flimsy, very pliable. It's meant to be that way. When you're inserting the device, I highly encourage to either use a method of kind of using your finger as a stylet as you're going through the cervix, or if you have bigger hands than mine, you can, pinch, but pinch higher up. If you're pinching down even here, and you're going and you hit any tissue or cervix, it's potentially going to fold back on you and you're going to feel resistance when inserting it. So the very first step to using JADA is to take that air out of this donut. So we have a little saying, you take the donut down to a raisin or a dumpling. So just pull that air out using the 60 cc syringe. And this is what it looks like before it's actually inserted into the patient. Okay. This is my uterine model here. It's very lifelike, as you can see. Boggy uterus, very short vaginal canal. The gray part is the vaginal canal. And inside, you can see that rim. That's supposed to represent the external os of the cervix. So as I'm inserting this in, if I do a sideway view, it's going to land somewhat like this. So that balloon should be in the gray part, which is vaginal canal. It should be right up against the external os, and then the actual JADA is in the lower uterine segment. So I will go ahead and show you an example of the seal, the cervical seal, when it's inflated with fluid. We don't care what sterile fluid is utilized. We just don't use air. This is an example right here of 60, and this is an example of 120. So every JADA looks the same when it's inserted into the patient. And then when you place it, you keep your fingers in place, and you're determining how much fluid is getting pushed into the seal based upon mom's anatomy. So just to give an example, my model here, who's got very firm and dry tissue, when I do her, I utilize the 60. So a larger subset of your patients are really going to be that 120. So I do steer providers to the 120. It's also one less thing to troubleshoot. You know, you have enough fluid in the seal. Just an example, in the hospital I was talking to this morning, they had mentioned they saw a little bit of bleeding around the balloon after they put JADA in. We were talking through, they had put 60 in the seal. So I encouraged them to add more fluid to that seal. And it's just like a water bottle. If you tip it upside down and you're seeing fluid coming out, you instinctively know something's wrong with my cap. If you're seeing a bleeding source after you've gotten JADA in place and inflated that seal, if you know you haven't put the full 120 in, likely you just need more fluid. I hope that makes sense. So as I insert this device, I'm going to pinch up here and I place it into my patient. A little hard to do. I'm going to actually take myself out of the camera so you can see this. There we go. That's better. So I'm going to go ahead and feed this through and keep my fingers in place. So in a real patient, you're going to keep your fingers in place, and you can see that balloon is right there. And I'm going to take it out so that I can get my syringe, and I'm going to turn it. So you can see as I'm pushing that fluid in, this balloon is expanding and it's getting tight up against the vaginal tissue. So once it's inflated, as I said, for my model here, I've done 60. You can see there is no gap between the vaginal tissue and JADA. So it should be nice and tight up against that vaginal wall so that nothing is coming out. And that way everything is then going to come out of my tube. So as I'm ready to hook it up to the suction, this is where if there was bleeding around the balloon, now imagine the vaginal canal is a little bit longer, you would see like a source, and we would know, hey, I need to put some more fluid in. So once I get that, I hook it up. Everyone can see my uterus, right? There we go. So we hook it up to the suction, and you should be looking for two things, tone and tube. So in a vaginal delivery, you're going to be feeling, am I feeling an inducement of that tone? And as that's happening, we should be seeing an evacuation of air, blood, and fluid out of the tubing into our 12 feet of tubing. So the average time, like I said, to collapse of the uterus is 60 seconds. And average time to control of bleeding, which is where does it stop in my tubing, was 3 minutes. It's important to note that the average blood loss after JADA was placed was 125 cc's. This tubing we provide holds 100. So it's very common that your bleeding may not actually reach your canister. You might see it stop somewhere in your tube. That does not mean there's a clot or that anything's wrong. That's actually the desired result. And, very common that you see it actually stop, say, right here. Because if you think about it, how quickly the uterus is collapsing down and closing those blood vessels off, we should expect to see it stopping. Once the patient is on JADA, we have her collapsed. We want to keep her on to move to the treatment phase for a minimum of an hour. The average treatment time per the study was 2.5 hours on continuous suction. And then after that, we have a 30 to 60 minute observation period where you would just reverse your steps, take your suction completely away, and then take your seal down so that JADA is actually just in the patient passively. So there's an exit. We wouldn't want to leave the seal up because then we're trapping everything in if the suction's off. So we take the seal completely down after that treatment time. And then we leave JADA in place. This is just taped to the patient's leg. 30 to 60 minutes. This gives us time to observe and see if mom's atony has been treated and if her uterus is now going to function on its own to control the bleeding. During that time, if she gets atonic, if we start seeing a clot, if there's anything that looks like, hey, you know, she's going to have atony again, we now have JADA in place where we can do our, you know, fundal massage at the bedside, but then also decide, hey, do I need to go ahead and reinflate my seal and put her back up to suction? And so we would just reinflate the seal and then put her back up. So we do have that observation period built in. And again, from a JADA standpoint, it's minimum of 30 minutes. With this, the big thing to know is just in terms of the treatment time, there's not a benefit. If you've seen your bleeding controlled since minute 3 and 2 hours later, you haven't seen any advancement and she's stable, there's likely not going to be a change from 2 hours later to 10 hours later because we're giving her that contraction. So the only way to know that we've actually treated the atony is to give her that opportunity to show us if her uterus is ready. And then once we're ready to, you know, we've decided, okay, we're trialing her off, she does her 30 minutes and we're ready to remove it. Removal is very easy. It's just support at the abdomen and then remove the device. There shouldn't be any tension. Again, this is deflated when we remove. There shouldn't be any tension when you remove it. It's just supporting at the abdomen and then pulling the device out. I do also want to go over C-sections. So this is utilized in C-sections as well as vaginal deliveries. In terms of the C-section, the on-label instructions for use say a minimum dilation of 3 centimeters prior to insertion, and that it's placed transvaginally. The hysterotomy needs to be closed, but the patient's abdomen can still be open. And we do go over and teach the nursing staff, how do we get out of the OR? So if you place this in the OR, we don't want to stay in there for an hour, and we don't want to break the continuous suction. So there is a very simple trick that we show the nursing staff. I'll just show you really quick. You go over, imagine this was a wall suction, go over to your suction source, pinch your tubing, and then disconnect as long as it stays closed. So you can either get an instrument and clamp it off, or a Lorlock syringe will fit into the bottom of the tubing. And then as long as this stays closed, as you can see, it will maintain that collapsed uterus. So you can get the patient to wherever you need to go, whether it's from the OR back to the PACU or to patient room, or if you decide that you need to escalate care for if this is a diagnostic tool and you determine that it's not actually atony and you need to further treatment, either going to IR, you can transport the patient to IR, ICU, anywhere with JADA in place if you feel like that is a necessary next step. And that is some of the feedback we've also heard, is that this does serve as a diagnostic tool because you're able to know if it's working or if it's not working within such a short amount of time. You can move into your next phase of care and get that patient to wherever she needs to go to get treatment if it's not actually atony. Some contraindications in terms of, you know, who's not a candidate for JADA. Your patients that have a ongoing uterine laceration or uterine rupture are not a candidate. And it's the ongoing piece of that. So once you've repaired it, then you could utilize JADA. An ongoing uterine inversion, place it back inside, and then you could use JADA. Infection with a purulent discharge or cervical cancer. And with both of those, the thought process is you're taking infected cells or cancer cells, pushing them through into the uterus. So chorio is not listed as a contraindication. Known uterine anomalies, and that's basically we didn't study them, so we can't tell you that they're going to follow the same efficacy as the study that was done. Fibroids are not listed as a contraindication. And my always favorite, continued intrauterine pregnancy. So if there's a baby inside, don't put JADA in. And that's it. I think, Terry, did I leave any off? I think I got them all.
I would just say the only thing to add, not that it's a contraindication, but just JADA wasn't studied with patients with known accreta or abnormal uterus or uterine anomaly. Did you say that?
I did. Yeah.
Okay, sorry. Was not studied with accreta patients.
And the accreta patients are actually that's some of the feedback we heard in terms of the diagnostic. We did hear of a patient who had JADA placed and it didn't follow the norms of the study, and they did ultrasound, determined that the patient had accreta. So they left JADA in place, but they did escalate care because it wasn't acne. That's pretty much the nuts and bolts of the demo. So like I said, we will leave the uterus there, and we will have the components so that you guys can practice with it and practice placement. And then of course, we're going to be on the unit every day this week at certain points. So would love to meet you in person and let you get your hands on it. But is there any questions or concerns, barriers to usage that we can address while we're here on the call?
Charity, just to clarify, you said choreo is not a contraindication.
Correct. Exactly. That choreo, and the choreo is one of the reasons we see uterus does not function. So absolutely, definitely want to make sure that's clear. It is not a contraindication, can utilize JADA.
Perfect. Rachel, can you share the INOVA protocol slides real quick?
Absolutely.
I'm just going to go over some INOVA specific protocol that we have that was developed from Fairfax that's going system-wide. So this is not part of JADA, this is part of INOVA. We want you to use the JADA device after a vaginal delivery or C-section when you suspect acne. You want to make sure these criteria are met. One is that you've tried at least 2 medications to control the bleeding, so TXA and PIT, for example, or any other urotonic. You have concern for ongoing bleeding, and that you've confirmed that you don't have any retained products of conception. So for INOVA, we're only using the JADA for acne and not necessarily for other abnormal uterine bleeding. There will be a survey that has to be filled out after every JADA use. And that's a survey for both the provider and the delivering nurse. And then you can these surveys will be taped to the box. So make sure you just submit it to the charge nurse. We want all patients to get a post-delivery CBC if you use a JADA 12 hours after delivery. In terms of antibiotics, ask consider an antibiotic, but they don't say it's mandatory. At INOVA, we request that all patients get a dose of ANSEF post-delivery. All our patients who have a JADA will remain on L&D unless you're in the process of acutely transferring the patient and you, for any reason, are not able to remove it. But we won't be using the JADA on FCC or other units. The instructions on the JADA, like Charity mentioned, is a minimum suction of 1 hour. But I think from the study, I haven't looked at the study specifically myself, but from the study, the average time was 3 hours. So this included 2.5 hours of continuous suction, and then you monitor for 30 minutes. But minimum, you want to use it for at least 1 hour. And do not leave the JADA in place for more than 24 hours. Any questions?
Sam, I have a quick question. You said we're not going to be using it on other units, but we can use it.
Nope, we lost you, Steph.
Doing it on FCC, but what about other units that have a higher level of care?
You mean in the ICU?
Yeah, like ICU or IR.
Let me clarify. My understanding is you have to have suction, and I don't know if, I mean, ICU definitely have suction, but I don't know about IR.
Well, she had just mentioned that if you clamp it, you would still maintain the suction. I mean, I guess this would just be for like temporary use, like you're escalating care. So you would leave it in place until that care was done and then remove it.
Yeah, because I don't think you get the full 80.
Right.
With just clamping it, correct?
So it will maintain whatever the suction was at, as long as it remains a closed suction. So it doesn't have a suction source, but it's going to maintain the same collapse. So here I'll show you. I'm disconnecting it from my suction source. See, there's no change. So it'll, as long as this stays a closed system, there, it doesn't change in terms of what the pressure, the negative pressure that was created. And the, so I guess it's safe to assume it would be like 80 if you were to measure inside right now, because it's never been interrupted. But the minute I let go of this, that's where it would start to lose whatever suction was in. So the biggest thing is making sure that it stays collapsed, or stays clamped rather. And we see that happen, you know, like I said, in other facilities where if they've decided to escalate care, they won't take JADA out, because like in the Akrita situation, they said that it, you know, they don't know what benefit it was causing in terms of controlling some of the bleeding. So they left it in place, transported with it clamped off. And then once they got to IR, they actually left it in place while the patient was treated in IR. I think it was IR or wherever she went to, but you can definitely transport and keep it collapsed, and it should maintain the same pressure as when you disconnected it, as long as it stays a closed system.
Where that's most commonly used, that transport hack, is typically when it's a C-section. It gets placed in the PACU or in the OR, and then you're transporting to recovery. That's most of the time when it's used.
Yeah. But Steph, I will clarify and get back to you about our specific protocol.
Sam? Hey, can you hear me?
Yes.
It's Andre. I'm driving, so I couldn't look at the slides. But did you say everyone has to get ANSAF with the JADA? 2 grams of ANSAF? Is that what you said?
Yes, for INOVA.
Okay. All right. Thanks.
Thank you.
In terms of JADA, just in case if you do work at any other facilities that also have JADA, JADA doesn't give a specific direction in terms of antibiotics, but it does say for prolonged use, for prolonged indwelling, consider antibiotics. And most of the time, the feedback we hear is if a manual sweep is being performed, a lot of providers are giving antibiotics. So definitely, JADA doesn't specifically say antibiotics, but I think it's commonly done from what we're hearing.
Any other questions? No, this is great. I think I'm very excited that we're finally getting it. And our go live date, I think, is next Monday. So there's a couple of things we're still trying to sort out from a process, issue with the suction and everything, but I'm hoping that will be figured out by the end of the week. So we'll be good to go on Monday. But I will have Charity's information and Terry's information in the lounge. Any INOVA specific issues, you guys can send me a message, text me, or call me.
And I just want to also mention that, once you go live and we've launched, we've educated it, our education doesn't stop there. We actually like to come back 2 to 4 weeks after, have another presence on the unit. Ideally, there's been a usage, we can address questions. And then we do continuing education and have a presence just to make sure that everyone feels comfortable, confident. New physicians come in, new staff, comes in. So we're in there very frequently. So you'll get to see our faces a lot. We just want to make sure you guys feel supported, and that doesn't just stop with, the initial like, okay, here's JADA, and then you never see us again. We're accessible. If you'd like us to come to your offices to do like a lunch and learn, and spend a little more time, that we're very open for that. Would love to do that as well.
And please come say hi if we're in the unit and you guys happen to be there. You can play with it, but at the very least, just come say hi.
Yeah.
Great. Yeah, and I have your schedule up too. I've sent it out as far as when you're going to be on the unit. So.
Thank you.
All right.
Everybody,
thank you for giving us this time. We really appreciate being able to reach your providers in this time. So thank you for organizing this, Dr. Berhanu.
Sure. Yeah, and then just let everyone know we'll have another virtual session on Friday. So just share it with everyone in your group. Bye, everyone.
Thank
Bye.
you.
Thank
Thank
you.
you.
Bye.